Hello and welcome to Building the Off-Ramp, Quality Connections to Care. For this webinar, attendees will be in listen-only mode. If you need technical assistance, please submit your questions in the tech support on your screen. If you wish to submit a question during the presentation, please use the Q&A window on your screen. We will try to answer all questions during the webinar. But if an in-depth answer is needed or we run out of time, we will try to answer your question at a later time via email. The presentation will now be turned over to Ashley.
Thank you very much. My name is Ashley Kreider, and I'm a Senior Project Associate with Policy Research Associates, which provides training, technical assistance, and research around generally the intersection of criminal justice and behavioral health. I'm very excited to have an opportunity to moderate this panel this afternoon, which is focused on making quality connections to care at various points across the criminal justice system, where there are opportunities to deflect and divert people with mental health and substance use needs, people who may be, as was said in an earlier session, experiencing their worst day. Today, we'll hear from 3 communities that have successfully built a broad range of diversion and community-based services. We'll hear from Spokane, Washington, Philadelphia, Pennsylvania, and Johnson County, Kansas. And I've been privileged to work with each of these communities in some depth, and I'll be introducing our presenters as we go. But first, I'd like to touch on a few points to just set the stage. So first of all, who are we talking about? Just to focus in a little bit on our population, we know that about 3 to 4% of folks with behavioral health needs are found in the general population. So everyone outside of the criminal justice system, about 4%. We also know that people with behavioral health needs are overrepresented in the justice system, particularly in jails and prisons. And you can see data here as far as rates of folks with serious mental illness in jails. Again, this is not looking at all mental health needs or all mental illness, but only this narrower serious mental illness category. So you can see that rate jumps up quite a bit when we're going from general population to the justice system and jails in particular. Accordingly, we also know that about 72% of folks in jails with serious mental illness have also co-occurring mental illness or co-occurring disorder. So you can see that once we look at the justice system, again, these rates of people with these pretty acute needs are very high. And we also know that folks with behavioral health needs tend to have longer lengths of stay in jails and prisons than folks without those needs. And so all of this kind of leads us to ask, is there a better way? The sequential intercept model is one framework that was developed to address diversion and deflection from the criminal justice system. This was created in the early 2000s as a kind of conceptual framework to help communities identify adults with behavioral health needs in particular in the criminal justice system or those that are at risk potentially of entering the justice system, as well as increase connections to care, analyze gaps and opportunities towards enhancing both public safety and improved quality of life. And you can see some resources here for a little bit more background on the SIM. This is a visual of the sequential intercept model as it's laid out in a linear fashion, and you can see these different intercept points or kind of series of moments, and each intercept highlights a key part of the criminal justice process. You'll likely hear the word intercepts referenced throughout today's presentations, but basically what this model does is to illustrate how people typically move through the justice system in at least semi-predictable ways, and again, where there can be opportunities for deflection and diversion. However, when we mention deflection, diversion, response, reimagining response, it's really vital that we consider not only that piece, but also community capacity for services and alternatives to incarceration. Often this question of divert to what or divert to where will come up when we work with communities. So we're ultimately talking about transforming the entire system. In order to do that, we need to consider not only a first response, but a second response, especially when we're talking about reimagining some of these models and what it might look like. We need to really focus on the capacity of the community to help support individuals. And these are some questions that 3 communities today will talk about answering. So I am going to introduce our first set of presenters from Spokane County, Washington. And they are Jan Takamoto and Sergeant Jay Kernkamp, if we could pull up their videos. Jan is the Chief Operating Officer at Frontier Behavioral Health, where she has clinical and operational oversight of outpatient crisis response services and programs funded by a class action lawsuit known as Trueblood. She's collaborated with the Spokane Police Department to provide Crisis Intervention Team or CIT training and other training including suicide, homicide risk assessment, diversity, equity, inclusivity, mass shooting, and trauma-informed care. Sergeant Jay Kernkamp is a Spokane native and is now the Behavioral Health Unit Supervisor with the Spokane Police Department. He has worked in a variety of fields, including the Regional Drug Task Force, Anti-Crime Team, SWAT, and the department's Peer Support Team. Jan and Sergeant Kernkamp, I'll turn the presentation over to you.
Thank you, Ashley. Good afternoon, everyone. I'll tell you a little bit about Spokane and about Frontier Behavioral Health, and I'll have the sergeant speak with you about the Spokane Police Department. So Spokane is located in eastern Washington, and we're the second largest city in the state after Seattle. You've probably all heard of Seattle, but probably have not heard very much about Spokane. We have, at Frontier Behavioral Health, we are the largest behavioral health provider in eastern Washington. And we serve individuals of all ages. We have over 700 employees throughout our agency in 18 different locations throughout Spokane County. As part of the service package that we have, we operate a regional crisis line that covers not only Spokane, but 5 other counties in eastern Washington. And this is a 24/7 regional crisis line that will also house 988 and take lifeline calls. We also operate 2 16-bed inpatient psychiatric facilities for voluntary and involuntary treatment for individuals 18 years of age and above. And we have 1 16-bed stabilization unit where we provide oversight and monitoring. In Washington State, our behavioral health care system serves an estimated 24% of the state's adult population, which is among the highest percentage in our nation. We have a poverty rate that makes it pretty challenging in eastern Washington to serve a lot of individuals. Frontier primarily serves those individuals who have Medicaid. Jay, would you like to share something about the Spokane Police Department?
Yeah, so Jen spoke a little bit about the Spokane area, so I'm not going to repeat all of that, but Spokane Police Department currently has about 320 sworn. We're scheduled to hopefully bump that up to near 360. However, we're still facing all the hiring barriers that everybody else is facing currently, so we're taking applications if anybody's interested. But also, we pride ourselves on being very progressive. All our officers are CIT trained within the first year. And throughout that, we also have advanced CIT to where officers are able to go through additional training throughout their careers to include motivational interviewing and other links to where that helps them build the bridge throughout community members.
I'd like to talk about our co-responder teams. I need to go back to the other slide. So our co-responder teams are funded by a class action lawsuit that's called Trueblood versus Washington State. And as you can see in this slide, there was a reason why this class action lawsuit came about. And it was basically because we had individuals who had a mental illness or a substance use disorder that were waiting in jail much longer than the 7-day admission for competency services and 14 days for competency evaluation. A lot of these individuals were remaining in jail for an inordinate amount of time. And so this class action lawsuit was filed because of an issue of due process. So out of this lawsuit, we originally received funding for 4 co-responder teams, and we have added to these teams over time. Now, this class action lawsuit was on behalf of Disability Rights of Washington, and this was settled in 2018. But prior to the settlement, the U.S. District Court Judge Marcia Peckman ordered the Department of Social and Health Services to pay more than $80 million in contempt sanctions. And she used those sanctions to then fund diversion programs such as our responder teams. In terms of the contempt fines, you can see that these are grant-funded programs that we have. So we have this $90 million in contempt fines to the courts, and the court continues to collect these fines, but they are not holding the state to these fines as long as the state is able to be in substantial compliance with the settlement agreements that were drafted with Judge Peckman. Out of these contempt fines, you can see that there were 4 phases to the grants. The first phase was really focused on jail booking and jail reentry, and then the first and second phase. And in the third phase, it was targeted towards crisis response and community supports. And that's where we received the funding for our co-responder teams. And then the last phase of this grant is dedicated to housing. And you can see that there was $20 million that was offered throughout the state for people to submit to try to obtain these grants for housing. This slide shows you what the goals were for these diversion services. And really, the goal was to try to leverage the services of multiple agencies and systems of care statewide so that we could prevent the overuse of the highest and most intense resources, such as psychiatric hospitalization, emergency rooms, and jails. Jay's going to share with you the contract that we have under WASPIC and the types of results we're getting, as well as under our Disability Rights of Washington contract.
So currently, under our WASPIC contract, which is Washington Association of Police Chiefs and Sheriffs, we have 7 co-responder models that are boundary lists that respond throughout the entire county. And what makes them unique with our unit is that we've changed the call types, we've changed the clearance codes to where we're actually responding in progress to crisis, and that we're giving them upfront services right when they need it. It's been very, very successful. We're able to build rapport with individuals that has helped down the road when major incidents occur, but also connecting them to services right when they're willing, able, and need these services has been a huge success, breaking that recidivism and then connecting them to care. Under the DWR, we do have 4 co-responder models, and we've actually assigned those to our patrol division. So every shift is assigned 1 clinician, and they rotate through. And this clinician is designed to ensure that patrol officers are aware of services available to individuals to assist with housing, shelters, food, clothing, whatever the needs may be that may cause this crisis and why law enforcement's there in the first place. It's been very successful. When we talk about that sequential intercept model, and CIT International addresses that as well, of introducing law enforcement to the scene. Law enforcement's there to make sure that everyone's safe. The real work that is applied here is allowing these clinicians and to connect with services and to do those introductions to the officers to build that rapport so that the next time we're able to pick up where we left off. One of the things that we've been really successful with in the 3 years of implementation of this program is that we've had 1 use of force, which was a taser application. Other than that, no other uses of force have occurred. And I can tell you countless and countless stories on a monthly basis of the ability that we are to outreach to the community, and how we're able to prevent individuals from re-entering crisis. One of the things that we also are able to provide is that we provide a follow-up list, and with that follow-up list is once this individual is out of stabilization, back in their individual housing or residential housing, we're able to connect with them, follow up with them, ensure that they're getting the medication, ensure that they're having the food, clothing, shelter, everything that they need while they're in a compensated state, so that they know that it's more than just a one and done. And by doing so, we're able to prevent them from going back into crisis again, because we're able to monitor them and assist them in making sure that they're staying on track with what their needs are to live within the community. Jan, was there anything else that I needed to add that you might have skipped over?
Our co-responder teams are based on a long-term relationship that Frontier Behavioral Health has had with the Spokane Police Department. And that's a relationship that goes back about 20 years when we first started CIT training together. And we have maintained that training up until now, where together, Sergeant Kernkamp and I work to create the CIT training and add to it, along with the Criminal Justice Training Center, who participates and oversees what we're doing with CIT. We have really taken this partnership into this co-responder team to the degree where Frontier will interview the mental health professionals that are candidates for our co-responder teams. If we determine that that person is clinically sound as a candidate for our co-responder team, then the next level of interview occurs with Sergeant Kernkamp and other law enforcement personnel. And we have an agreement with law enforcement that if the individual is not a good fit for law enforcement, then they will not be added onto the co-responder team. And we've been pretty successful with this model. I don't think that we've ever really disagreed on a candidate, and there have been people that Frontier has moved forward that law enforcement was not comfortable with, and we did not go with the candidate. Along with this relationship is the training that we provide together. We, as Sergeant Kernkamp mentioned, we use motivational interviewing as a foundational piece for our co-responder teams. We train our teams together. We happen to have an international expert on motivational interviewing. His name is Casey Jackson, and he happens to live in Spokane. And he provides all of our motivational interviewing training for our co-responder teams. And it's been such a successful model that we've been using. Casey Jackson uses body camera video from officers to illustrate the use of motivational interviewing with individuals who have taken the training, and then also show situations where motivational interviewing was not used because officers may not have had the training. So we will train together on topics like motivational interviewing, risk assessment, safety training, and we find that by training together, we then are of like minds, and we're able to operate as a team together on these responses that occur. When we created these co-responder teams, the one thing that we looked at was what were we sure we would need in terms of resources, because we needed to give our teams something concrete that they could rely upon when they were involved in an intervention and trying to de-escalate a crisis or stabilize a situation. So when we applied for these grants, we wrote into the grant the cost of a shelter bed at our local shelter. We also wrote in the cost for 2 beds at our detox and withdrawal management facility. And with our shelter bed, we also wrote in that the individual would receive assistance to try to find permanent supportive housing, that the staff at the shelter would assist with that. And then with the withdrawal management beds, we wrote into that contract that there would be the ability to transfer the individual to an inpatient or outpatient services. In 2021, we added a couple more resources, and one was the use of Frontier Stabilization Unit, and we added this drop and go concept where an officer on our co-responder team could contact the stabilization facility, provide some information, and then transport that individual, drop and go. And what that did was it allowed our co-responder teams to get back into taking calls for service. We also added a substance use disorder assessment that could occur by phone with one of our local substance use disorder treatment providers. And by making that phone call, that assessment could be done to determine what level of care the individual needed. And then that substance use treatment facility would assist us in finding substance services for that individual. We'd like to show you a quick video to give you an idea of how our co-responder teams operate. So Ashley, if you could.
He's schizophrenic, according to his mom, off his meds.
Spokane law enforcement officers, along with Frontier behavioral health clinicians, are changing the way our police and sheriff's deputies respond to people in crisis.
With everything you got going on, are you having any thoughts of wanting to hurt yourself or hurt anyone else?
Jenny Mandan is a member of Spokane's behavioral health unit, a blend of cops and counselors working together to find real solutions to their clients' recurring mental health problems.
I think when people can recognize a face when they're in crisis, that's instantly de-escalating.
A suicidal female lost her husband a month ago, been drinking and contemplating suicide ever since.
1 out of every 4 calls police respond to involves someone suffering from a mental health problem. This joint city-county program allows mental health professionals to deliver care and resources in an environment that's safe for everyone.
Just being a mental health clinician, that really allows me to identify what's going on with them and relay that information to any helpful intervention that comes later on down the road. Hey Wayne, my name's Jenny. Have you been sleeping lately?
In April of 2020, 70% of this unit's contacts led to resolutions that did not involve clients going to the jail or hospital, and none of those 222 cases involved the use of force beyond handcuffing.
When you establish that that rapport with somebody, the next time that they're in crisis, you go back and you say, "Sean, it's me." It de-escalates 100% right there. There's a suicidal male standing on the north side.
De-escalation means saving lives and preventing injuries, like the man who called 911 to say he was jumping off the Monroe Street Bridge.
The subject did not jump off the bridge. We're able to take him into protective custody, and we are taking him to Deaconess for an evaluation.
The behavioral health unit assumes responsibility for checking the man into the hospital.
See, I'll do all this. It's just I need to get him inside.
Freeing up patrol officers to respond to other calls for service.
Robert, right? Yeah. All right, Robert, we'll get you inside here. I'm going to do out some paperwork. Cooperate with them, and they're going to get you the help you need, all right?
While Officer Flynn helps Robert inside, Jenny documents this man's case in the hopes of connecting him to outpatient services in the future.
When you look at somebody that's contemplating suicide, that's a permanent solution to this temporary problem. There were things in his life that he needed to work out, and he hadn't worked them out. He was choosing reckless behavior. We'll recommend they call you from a non-restricted number.
30% of the time, a visit from the behavioral health unit results in someone accepting a referral.
We really want to leave it on a positive note. You know, whether they want services or not, we always want them to leave knowing that if they call the police, they're going to get support.
You okay?
Spokane's behavioral health unit is funded by the Washington Association of Sheriffs and Police Chiefs. Their groundbreaking grant is an investment in helping people find new avenues to their recovery.
No matter what, humans are humans, and we are here to help humans. And whatever someone's going through, there's always an opportunity to change, and we want to be that changing factor for them.
If you or someone you know needs help with mental health solutions, call Spokane's Regional Crisis Line 24 hours a day. Jeff Humphrey, City Cable 5.
So that gives you an idea of our how our co-responder teams operate and how they partner together and approach every situation together. This slide here just shows you some of the community resources that we found were really necessary to support these co-responder teams. And you can see that many of the resources involve housing. It is not uncommon that the majority of the people that we are seeing are unstably housed or they are homeless. So housing is an issue, and then also substance use. That is something that we come across with practically every individual that we have contact with. And then again, our stabilization unit, which provides that observation and monitoring for individuals that are really decompensated or need more oversight. The next slide is just a list to show you some of the other True Blood resources that Frontier Behavioral Health has been successful in obtaining. And a lot of these resources are specific to housing. The one that we just received was our housing grant, and it was a $6.8 million grant that we were successful at receiving, which will end up with provide us with 34 housing units that we can use with True Blood class members. So hopefully we can house them so that they are stably housed, and we can divert them from emergency rooms, inpatient psychiatric treatment, and jail. Thank you.
And Jan, just real quick, one more thing to add is the biggest lesson that we've learned is having community partnerships and engaging in them. Jan and I sit together on a weekly basis discussing, individuals that really we need to focus on that are high calls for service, high utilizers of services. This decreases law enforcement response, but it also increases the safety to the public. We sit on several boards throughout the county, engaging the emergency rooms, and it's a collaborative effort that we try to work with just to make sure that everybody's aware of each other's efforts and trying to kind of address some of the concerns that we have within the public. And to us, it's amazing some of the collaborative efforts that we've been able to achieve by having these meetings and the support throughout the community. And that's one thing I'd really encourage everybody to try to focus on, just to be successful within their own communities.
So we are going to hold questions to the end. We've got several coming in already, but thank you both Jan and Sergeant Kernkamp. I really appreciate you emphasizing both this longstanding relationship between behavioral health and law enforcement, as well as how in Washington State, the competency process really sparked a wider expansion of alternatives to incarceration. So thank you for that. I'd like to turn it over next to Philadelphia and Rachel Eisenberg. Rachel is a Philadelphia native who currently serves as the director for the City of Philadelphia's Office of Criminal Justice. In this role, she oversees the city's efforts to advance racial equity in the criminal justice system, foster meaningful community engagement in justice reform efforts, increase early diversion and reflection, and safely reduce the local jail population. Rachel, I'll turn it over to you.
Thank you for having me here today. Thank you all of the participants for joining. I'm going to spend my time talking about the city's 911 triage and responder strategy, which is basically a collection of new initiatives and reforms that are building on long-standing partnerships between our behavioral health systems and our law enforcement. So as you may know, Philadelphia is a city of 1.5 million, and what makes our city unique is that it is both a city and a county. So the functions that traditionally fall under city government as well as county government are in many ways one and the same in Philadelphia. And so we have, one municipal police department, which has, created a lot of opportunities for partnership with also our local Department of Behavioral Health. And so there's a long-standing history of collaboration between these two departments, including our crisis intervention team training program that has been part of the city's training of law enforcement since 2009. In 2016, the city began its participation in the MacArthur Foundation Safety and Justice Challenge, where we developed and began implementing more diversionary and deflection opportunities away from the criminal justice system, in particular for people who have mental illness or substance use disorder. We began implementing and have since been growing a pre-booking diversion effort that provides harm reduction services for people who encounter police for low-level offenses associated with unmet health needs. And I mentioned this program in particular because there is, great synergy between the services that are provided for that program and the other efforts that I will mention later in my presentation. We actually got our initial start with corresponding teams associated with our police-assisted diversion program, where we had teams of actually active outreach co-responders. So folks who are in particular in one of the neighborhoods in our city hit hardest by the opioid epidemic. We had teams of co-response units actively engaging with folks in the community that had previously, had contact with our pre-booking diversion program. But we came to recognize that there's an even greater need for kind of upstream or interventions earlier in the sequential intercept. So at intercept 0, there was a concerted effort by the partners in the city, our office, the managing director's office, which is part of the mayoral administration, along with our partner departments in the police department and the Department of Behavioral Health, to kind of think at even the earlier moments aside, say when someone calls 911, that someone might be encountering the system. So our 911 triage and responder strategy is made up of 3 main components, but it's really designed to better identify when people are calling 911 in relation to a behavioral health crisis, designed to expand the range of responder options that are available to meet the needs of the person calling 911. So, currently, the primary responder option is law enforcement, and there are absolutely instances when they are the appropriate responder option, but was a need to build out more options. We also have the fire department and emergency medical services, and so thinking about kind of a continuum of options for people experiencing behavioral health crisis, and then to really implement policies and practices that triage the calls that come into 911 to the appropriate response option in real time. So, okay. And so I pull up this slide just to give folks a sense of when we began this work, it was really important for us to kind of take stock of what was already happening in the city and what resources existed in the community that, as we were building out alternative pathways for, first response when people call 911, we wanted to be able to connect with what existed in the community. So, as I mentioned, we already had our crisis intervention team training of law enforcement, and over 3,000 officers in our police department are already trained in crisis intervention team training. Again, we had our pre-booking diversionary program that, provided an additional option for law enforcement in lieu of arrest. We had, again, our active outreach co-response teams, and we began building, our other co-responding models. we have kind of our homeless outreach teams that exist in the community and their existing partnerships with law enforcement. So we had some resources out in the field to respond to people experiencing homelessness. We also, and I'll talk a lot more about this later, but we had 2 mobile crisis teams in the field who could provide kind of mobile crisis services. That capacity was insufficient to actually, provide a real timely first response when someone was calling 911 in mental health crisis. And so that was a gap that we identified early on as needing to really expand upon in order to have mobile crisis be an option for a first response for someone calling 911. We also had a crisis de-escalation line, and that's a 24/7 line that currently exists in Philadelphia that actually is part of our reform effort as well, to think about how we can transfer more calls from 911 to directly to the crisis de-escalation line. We have, we have emergency medical services teams out in the field, as well as some kind of alternative emergency medical vehicles. In particular, we have 2 vehicles that respond to the need for overdose reversals. And so we're currently working to consider expansion of that model and actually tie them more closely into 911. And then we also have, accessible to anyone in the community, crisis stabilization centers, as well as case management teams. And both of those services provide a pretty critical role as follow-up services for folks who encounter our co-responders or our alternative responder units. So as I mentioned, the city, the police department as well, who is the one who runs our 911 call center, as well as our Department of Behavioral Health, also in collaboration with our fire department and the managing director's office as well, embarked on some 911 triage reforms that were really looking at the policies and practices inside the call center and thinking about what additional mechanisms would be needed to really enhance the way calls are identified and the way that they're triaged to the appropriate responder. So one of the first things that we did was we revised a call taker script that was specifically aimed at identifying when someone was calling in a behavioral health crisis. And so the call taker script is, one of those linchpins of our strategy, because at the time we didn't have a really good way of identifying what the person was calling about, and in the event that it was a behavioral health crisis, what are some of the key factors that responders would need to know in advance of arriving on the scene. We adapted the crisis intervention team training for our 911 call center operators, and provided that training as well as sort of more ongoing collaborative trainings with them to help teach them principles of de-escalation and make sure that they have comfort utilizing the call script, and also creating a feedback loop with the call takers to make sure that their input is actually informing the policy development. And we embedded behavioral health navigators in the 911 call centers to help triage calls. This is a project that we're currently building out, where we're actually going to have crisis line operators inside the 911 call center who can actually dispatch crisis services, as well as actively de-escalate calls inside the 911 call center. So that's currently we do have navigators in our call center and as a pilot, but that's something that we're going to be growing in the new year. One of the key components of our strategy, which is similar to what my colleagues from Spokane were speaking about, is that we implemented, we're not as far along as they are, but we implemented a pilot program in April of last year, a crisis co-response team that can kind of be first responders to people who are calling 911 in behavioral health crisis. And so there are currently 2 ways in which our what we're calling our CIRT teams, our crisis intervention response teams, are dispatched to the scene. First, they can be identified by the call taker as the appropriate responder type. This actually happens not as often as either patrol officers requesting CERT units or the CERT units themselves are monitoring the radio and putting them, and the supervisors are monitoring the radio and putting themselves on scene. We found that actually that third option, them monitoring the radio themselves, has been one of the most successful ways that our CERT units have identified their appropriate calls, but we're currently working to enhance the ways in which our dispatchers are able to identify and directly dispatch the co-responding units. And so our co-responding units are, they're made up of, we currently have 4 in our pilot phase, and we will be expanding to 6 units citywide 24/7. But so our corresponding units currently are made up of a CIT trained law enforcement officer and our contracted behavioral health clinician riding around in a police vehicle together, responding to calls. And they also have access for every 2 co-responding teams to a follow-up team that is staffed by peer support specialists who can conduct the necessary follow-up. So once the situation has been de-escalated, perhaps someone needs to be transported to service connections in the community or needs a next day follow-up, our peer follow-up teams can handle that. And the teams of peer specialists, clinicians, and law enforcement officers went through a specialized training all together, strongly grounded in kind of reality-based training scenarios, and also the principles of, an advanced course in crisis de-escalation. And so that is a training that's going to be repeated as we grow the program. And I just, another kind of critical part of our planned reforms that again are coming down the pike for Philadelphia in the new year is to really think about the ways in which calls that are more appropriate for the crisis system as a first responder, how we can identify those through the 911 call center and actually transfer them directly to our crisis de-escalation line. So we are actively expanding the staff in our crisis de-escalation line. That is where 988 will be housed when it comes online. And we're creating better connections between our call center and the crisis line. So we currently do warm line transfers to our crisis line for suicide calls, and we will be expanding that, the call types that are going to be transferred directly to our mobile crisis line. Again, early in the new year, and then and so we will be revising our call taker script to really provide guidance to the call takers on exactly when calls should be transferred out of 911 to our crisis line. And then we will be expanding our mobile crisis teams fourfold in the new year as well, so that we can have, in addition to the traditional law enforcement response, the co-response, we can have a third response option and of course our fire EMS response. We can have a fourth response option for people experiencing mental health crisis, and that is the mobile crisis. Those folks are not currently dispatched to 911 calls, and that's something that we're planning to change. I think that is my last slide, but I know that we are also holding for questions, so I can pause there.
Wonderful.
Thank you very much,
Rachel. Thank you. I love that chart you showed. I think it's particularly valuable to show the really continuum of crisis responses that Philadelphia has explored to address a variety of individual needs versus kind of a one-size-fits-all approach. Finally, we have 2 stakeholders from Johnson County, Kansas, who will walk us through their data-driven approach across several intercepts. Robert Sullivan has served as the director of Johnson County Department of Corrections since 2018, where he oversees adult and juvenile probation, detention, intake and assessment, electronic monitoring, as well as an adult residential center. Before becoming the director of corrections, Robert served as the criminal justice coordinator where he provided internal support for the county manager's office on criminal justice related activities and served as the staff liaison and coordinator for the Johnson County Criminal Justice Advisory Council. Also, Tim Deweese, director of Johnson County Mental Health Center. The Mental Health Center employs more than 340 staff who provide behavioral health services to nearly 10,000 county residents annually. Tim is a licensed mental health professional in Kansas and has over 30 years of experience working across community mental health. Robert and Tim, thank you.
Thank you, Ashley. Appreciate the introduction. Today we're going to discuss how a culture of collaboration here in Johnson County has helped us commit to robust data development. It's also informed the way we allocate our resources. It has aided in the development of both our reactive and proactive response strategies to divert people with mental illness away from our jails. But before we get into that, I just want to tell you a little bit about where we're from. We're south and adjacent to the Kansas City, Kansas and Kansas City, Missouri metro areas, and Johnson County's population accounts for about a quarter of the total population in the Kansas City metro. So we have 20 cities and 17 different law enforcement agencies here. Our jail's capacity is just under 1,100 beds with an average daily population of around 857 before COVID. Since COVID, that average daily population has dropped by about 19%. And we've been holding steady at that 19% reduction. We were honored to be one of 4 jurisdictions to help launch the Stepping Up initiative back in April of 2015, and we joined the Data Driven Justice Initiative in 2016. But to kind of lay the foundation of our work, I really wanted to highlight 2 significant efforts around our data development that's really advanced our work here in Johnson County. So the first one would be our Justice Information Management System. We call it JIMS, and JIMS supports the public safety related departments in our county, and it does so using a fully integrated database. So essentially this means a single database tracks a person from booking into the jail via the district attorney's office review throughout the entire court process all the way on to probation. Because of JIMS, we could cross-reference about 32 years of jail data and about 28 years of adult court case information. Additionally, all but one municipal police department uses one record management system that is also hosted by JIMS. So with that, I want to hand this over to Tim. Tim is going to talk about another important milestone in our data development and also speak to the work related to the intercepts related to jail and reentry.
Thanks, Robert. So following a countywide audit in 1999, what was found was that there were gaps that existed in county services. There were duplication of services, and there were service delivery inefficiencies. To give you an example, we found one Johnson County resident that received services from 27 different agencies and had 17 case managers. In response to these findings, we created a web-based application called My Resource Connection, or MyRC. And really, the MyRC served 2 functions. The first function it served was to provide an opportunity to consolidate all of our community resources so that case managers and community-based workers could go to one place, one location, and access resources, know where the resources that existed within our community were. The second purpose for, or the second function for MyRC was really to serve as a data point, a data service shared database. And what that did is that every night, county services or county service data was uploaded into the shared database. A nightly process took place, and it identified individuals receiving services from multiple programs, and we referred to these as mutual clients. Staff in these programs then utilized MyRC to obtain information about other services a particular client or consumer was receiving, and then contact those other professionals about information that they had regarding the individual that they were serving. Staff access to the client database varied depending upon whether they worked for a HIPAA covered entity or if it was an entity that had a HIPAA Business Associates agreement. Next, I'll give you an example of that. And so MyRC, as I said, the county data was loaded into that every night, so it gave you real-time information. So for example, if someone called 911 and an ambulance was dispatched to their home, a mutual client alert would go out to the case manager real time and would be waiting there for them the next morning. That way, our case managers, if this was a client that was involved with the mental health center, our case managers would know that that occurred and then could begin to follow up immediately the next morning. The next piece that I want to talk about in regards to, whoops, went too far. The next piece that I wanted to talk about is the information that we gather at the time of booking. And so in 2016, we created an electronic version of the Brief Jail Mental Health Screen. This is what it looks like in the GEM system. And we incorporated that into our booking process. And so we, at any given point in time or any year, we're booking about 13 to 14,000 people in jail. So we're doing the mental health, brief mental health jail screen on every person that is booked into jail. I'll also mention that it is, I keep hitting that twice, sorry. I also mentioned that we also serve as the service provider in the jail. So we have a justice team that is in the jail providing all of the behavioral health and mental health services within that jail. So when we look at the number of people that are being booked in the jail each year, approximately 27% of the detainees are identified by the Brief Jail Mental Health Screen as needing further evaluation from a mental health professional. This gives us the chance to identify, engage, and improve the coordination of care for all justice involved individuals. It's especially important because more than 2/3 of the detainees are released within 48 hours. And so for those individuals that are released in 48 hours, we refer those individuals to our mobile crisis team for outreach. So that way it ensures that there are 2 opportunities for us to connect with someone, and I'll talk a little bit more about that here in a moment. Because of resources like GEMS, MyRC, and the Brief Jail Mental Health Screen, we have positioned ourselves to do the following: to provide local policymakers with a realistic assessment of Johnson County's current capacity to effectively serve this population, to promote new collaboratives and service integration opportunities that improve upon our efforts that already exist, and then for us to look for new partnerships outside of government to support the service integration and early intervention opportunities, for example, with hospitals, clinics, and schools. So I mentioned a minute ago about how we gain that information and about how MyRC works and how GEMS works. So GEM also provides us with real-time data. So for example, when we do a brief jail mental health screen and someone is booked in directly into the jail and they are a mental health client, then again, we are notified of that booking process, and we're notified of that that booking into the jail immediately. So the next morning, case managers will be identified. They'll be able to know that their client had an altercation or involvement with law enforcement and that they had been booked in the jail. If we look at the process that I mentioned earlier as well about having 2 opportunities to Seems like things are stuck. Well, I'll just keep going. If we look at how we can use that information effectively, you can see how the process and the work flows. We have two opportunities to connect with individuals to connect them effectively to care. The first opportunity is while they're incarcerated, and the second opportunity is through our mobile crisis response team shortly after release. So the question may be, how is this effective? Well, we have partnered with the University of Notre Dame to determine if offering mental health treatment for individuals screened for mental health issues released from jail actually reduce the likelihood of them returning. And the early results are very promising. Here are a couple of notes. The implementation of the brief jail mental health screen at intake decreases recidivism rates for those who qualify for mental health outreach. Second, individuals from Johnson County who qualified for mental health outreach had a 12% reduction in recidivism after 60 days, compared to a 4% increase for residents of other counties. Also notable was a decrease in recidivism rates observed after 180 days and 360 days, 10 percentage points and 9 percentage points respectively. Additionally, those who have never received mental health care before their jail booking also saw greatly reduced recidivism rates. Individuals from Johnson County who qualified for mental health outreach indicating no prior mental health care had a 23% reduction in their recidivism after 60 days. And with that, I'll return it back to Robert.
Thank you, Tim. I appreciate that. So now we want to talk about, Tim spent a lot of time talking about how we react to individuals that are hitting our jail. And so what we started to do to further our work around our data was to figure out a way to be more proactive and try and engage this population prior to another police interaction. And so in 2016 and again in 2018, we partnered with the University of Chicago's Data Science for Social Good Summer Fellowship. And we partnered with them to create an early intervention system. And so at that time, our public systems were often unable to link individuals with complex conditions to effective care in a coordinated manner. It was a little bit more fragmented than what we would have preferred, resulting in strained mental health and criminal justice systems that we felt could not fully meet the needs of our citizens the way that we wanted to. So to put Johnson County in a position to be more proactive rather than reactive, we worked with DSSG to develop a predictive analytics model to identify individuals at risk of interacting with multiple public systems as early as possible, so that we could successfully bridge data silos from various databases. And we were able to link individual level data across systems and then de-identify that data before sharing. So essentially, we wanted to figure out a way to identify those individuals most likely to have a police encounter resulting in a jail booking within the next 12 months and figure out what we could do to intervene so that that jail booking never took place. Seems like there's a bit of a lag on our slides. Here we go. So we've been doing that since 2016. And so what that partnership allowed us to do with DSSG was examine those individual high utilizers of multiple systems, track the context of their system interactions, count the number of interactions with different systems, and measure the time between system interactions. And we were able to do all this without infringing on their privacy. Many of these individuals repeatedly have cycled through our jail, hospital emergency rooms, shelters, or other services. So since our predictive analytics modeling went live in May of 2019, we've put it to work helping us connect people to effective care to avoid those future bookings. Each month, we will use our model and we will identify a list of 100 individuals that are most likely to have a police interaction that could result in a jail booking. And that list is shared with the Mental Health Center's mobile crisis response team so that they can begin outreach efforts. These individuals are folks that are identified as having that elevated risk. Whether or not they accept services is strictly voluntary. So far, since May of 2019, the response from individuals that have been outreached has been overwhelmingly positive. And if somebody asks not to be contacted again, we respect that. Right now, we're also partnering with Carnegie Mellon University to study this program's effectiveness. And so with that, that's the conclusion of the Johnson County portion of this presentation. And Tim and I both really appreciate the opportunity to get to talk about the work that Johnson County is doing with all of you today.
Thank you, Robert and Tim. So we're going to pull up everyone for some Q&A. We've got about 15 minutes left. And we have a lot of questions coming in. Some are being answered. Rachel's quick on the keyboard here. I appreciate that. And we've got some questions for Spokane, first of all. For the co-responder teams, Jan and Sergeant Kernkamp, who does the follow-up after the individual has stabilized? Is it a member of law enforcement or someone else on the co-response team?
That depends. We have two different. Go ahead, Jay.
No, go ahead. That just depends on the need for the individual and what best suits them. We're very lucky to have a mobile crisis response through Frontier that we're able to forward our follow-ups to, but also sometimes through rapport building, they've actually related better to our deputies and officers and those teams as they respond to them and help them, and they look forward to seeing them. So it's based upon need, services, connectivity, and availability. And we're very fluid with that, and we base it off just of what better suits them.
Thank you. So one other process question for Spokane around the drop and go admission. Someone writes, are those voluntary folks that are being dropped off, or if the individual is not voluntarily agreeing to this and is taken into law enforcement custody for their own safety, what happens at that point?
The drop off to our stabilization unit is voluntary. Jay, do you want to respond to those individuals that are involuntary?
Yeah, so for our involuntary, Washington State does have the Involuntary Treatment Act. We transport those individuals to the hospital. However, under that diversion and the criteria, if they fit something that we may feel safe to do so, and we're able to get them into an evaluation treatment or treatment facility, that's something that we do look at. It's just based upon how severe they are, how acute they are, and again, based upon their needs. We have a really good rapport with our designated crisis responders that go out into the field to assist with these civil apprehensions, and we constantly collaborate with them to try to figure out what is the best solution for them.
Thank you. So I think the next question came in during Spokane's presentation, but it probably could be asked across all three sites. And this is around the development of the relationship with your hospital emergency rooms. And this particular person is frustrated because they don't have a drop-off resource for law enforcement in their community and have independent hospitals. So could folks talk a little bit about the development of that relationship?
For Spokane, the sergeant and I communicate with them on a weekly basis or a daily basis if we need to. Spokane Frontier Behavioral Health also hosts a quarterly meeting. We used to meet monthly when we first started these meetings, but they are now quarterly meetings where I have all of the department directors of social work and emergency department directors at this meeting so that we can talk about processes and practices and together determine what policies would work for all of us and what kinds of concerns any of us might have that we can try together as a group to come up with a single practice among the 4 hospitals that we have.
And one thing that we really try to emphasize in those meetings is that not always is law enforcement aware of the outcome on the back end, and not always are the hospitals aware of the outcome. Say if they have an elopement, or if the physicians discharge somebody due to the emergency rooms being full, or if a behavioral health care provider drops somebody from services. So what we're able to do is work together to say, when you do this, this is the impact that it has on the community, and the extra workload that it puts on other teams' shoulders. And so we're able to try to navigate that and balance that to where what is best for everyone, but also the best care and best support for within the community.
Other thoughts from Johnson County or Philly? Rachel, I think you're muted.
Yeah, sorry about that. I was trying to say that in Philadelphia, we do have an additional resource that we call crisis response centers, but that are basically, crisis stabilization centers in the community. And so, it has been, our efforts have really focused, rather than on the hospital's emergency departments, on those crisis stabilization centers and making those, the drop-off process there more streamlined. I think that we encountered a lot of issues when we first started implementing our co-responder, where, a lot of work had been done prior to arrival at the crisis stabilization center to, get the person de-escalated and, get them to be receptive to receiving services. And then, the reception was not, was not always taking all of that into account. And so as we've been rolling out this model and our planning for our expansion of the mobile crisis teams, building, a much stronger relationship with those crisis responses has been what we've been working on.
Thanks, Rachel.
Yeah, Ashley, the only thing I would add, and I noticed Tim just was able to join us, but I know that when I was criminal justice coordinator, Tim's supervisor for the co-responder program and the chair of our CIT council, and at the time I was the criminal justice coordinator, we collaborated and went and met with hospitals. All of our hospitals are independent, but we went and met with them and talked about some of the challenges and how it wasn't necessarily consistent on what the response was from one hospital to the next. But it has been a challenge in Johnson County as well.
A specific question that you probably hear all the time, Robert and Tim, how can we get more information on My Resource Connection and JIMS? Who designed it, funded it, and who does the input?
So JIMS started in the early 90s. It was originally an off-the-shelf product. And I believe when the initial, I hope I tell this story right, but based upon the contract expired, Johnson County purchased the source code for that product. And since like 1993 or 1994, essentially, I think I was told 94% of what JIMS is today has been built by our local department since 1994. And so it's almost home built, and it's we can submit work orders and work very closely with JIMS staff to really make applications specifically to our needs. It's a very much a luxury. And then with MyRC, that too was home built in conjunction with United Way's 211 system. And another IT department within Johnson County was able to build that, and we continue to work very closely with them as well for the MyRC.
And I think I've heard you speak a little bit about helping to tailor that product or product like that for other communities. Is that something you can talk about a little bit?
Yeah, so we have an executive committee for the My Resource Connection that meets on these, and we have had some surrounding jurisdictions where we felt like there was going to be some overlap, that we have collaborated with them, and they also participate in My Resource Connection. But then we've also had other jurisdictions from across the country that asked if they had the capability, could they just take our MyRC application and then put it to work there locally? And what I'm told is that infrastructure is in place to do that, but we wouldn't be able to provide that technical assistance for it. That we would just be able to take the bare bones infrastructure of MyRC, and we could hand that off to another jurisdiction. That's what I've been told.
I think that the key in that, in a lot of respects, is being able to have all of the entities be willing to share their data and developing the right agreements to ensure that that's the place. Because I think that once you have the groups willing to share the data and you have the data to put in place, then you can find the architects, the engineers that are needed to be able to build that infrastructure. So to me, the hardest part was really getting everybody on board, being willing to share the information. And then, you know, it's kind of like data is gold. So you have institutions, not only data institutions, but higher education institutions looking to use that data. So you can make use of leveraging that with them.
Yeah, absolutely. I think you're hitting on a key point here, and I might open it up to Philly and Spokane as well. I know that data sharing agreements, information sharing, those sorts of things are parts of the work that you're doing across different systems and intercepts. Any thoughts on how to get started with that for communities that might be not quite as far along on the information sharing piece?
I think one thing that I will say is that I can't kind of re-emphasize more the importance of having really strong agreements that everybody signs on to, and what that provides to folks are protections too around their data. Thinking about what the approval processes need to look like that would make people feel comfortable having their data in a shared space, and recognizing that, you know, if it were to be, you know, redistributed to a third party, that they would have some say in how and when that gets done. Those assurances are incredibly important to get people comfortable with sharing their data, but it's true that there's nothing more valuable when you're thinking about criminal justice systems change, to really having the data you need to understand the way people not only are, where people are at any given moment, but how they flow through the system across the intercepts. And so I would just say that when you're thinking about bringing partners together around data sharing, making it clear that you understand that those protections are going to need to be in place.
Absolutely. Thanks. Spokane, anything on your end?
I would just say from our end, having success within the community is also getting buy-in from other officers and other agencies, and the importance of it, and having them request you, because we're such small units that we can't be everywhere, and training to the lowest, common denominator of saying, hey, I need you to be my A's and ears, and if you need something, please call for these units, because we are a resource to the community. And I need you to be able to recognize certain factors, so that if I can have, being aware of services, or being aware of facilities, and on the data piece, getting the buy-in of how much time that these co-responder models save patrol officers in recidivism, and going back to these places time and time again, that oftentimes from a law enforcement standpoint, they're very, very frustrated and feel like it's just a big gap in the system, where these co-responder models are able to connect them with services and stop that gap. but tracking that. So recidivism, use of force, tracking the time that we spend on calls, the how many people we refer to services, the amount of calls that these units take. Those are all things that we report on a monthly basis to show statewide what we're doing and how effective it is.
Absolutely. Thank you. And we are just about at time, so I want to thank all of our panelists. And there were a couple of questions that came in around the CIT script from Philadelphia, or excuse me, the call taker script at 911, and Rachel's graciously agreed to share that, so we'll get it to you. Thank you, everyone, and have a great rest of the day.
Thank you for your participation in this session, which we hope you enjoyed. You will now be brought back to the main room for wrap-up and team directions.